Hello, my name is Acanthamoeba and today I'm going to talk about Acanthamoeba keratitis. Definition: parasitic infection seen most often in contact lens wearers. It is often characterized by pain out of proportion to findings and the late clinical appearance of an stromal ring-shaped infiltrated. It is both difficult to diagnose and difficult to treat.
A microscopic waterborne amoeba. The disease tends to occur in people who wear contact lens. It can accompany a bacterial infection of the eye. Acanthamoeba keratitis can produce corneal ulceration and result in severe loss of vision and even blindness. Signs and symptoms are persistent redness and pain in the eye. Treatment is with multiple antibiotics, often including antifungal drugs, and sometimes surgery after the infection has subsided.
Application in medicine. Acanthamoeba keratitis should be considered in all contact lens wearers and in any case of corneal trauma with exposure to soil or contaminated water. Common symptoms are massive pain, photophobia, and tearing. The sooner the disease is diagnosed, the better the common be.
In this video, we are going to see about Acanthamoeba keratitis. This is a concise presentation for medical students. Keratitis is inflammation of cornea. So, Acanthamoeba keratitis refers to the inflammation of cornea caused by Acanthamoeba. It is a rare disease in which amoeba invade the cornea of the eye. It may result in permanent visual impairment or blindness if not treated properly. It has recently gained importance because of its increasing incidence, difficulty in diagnosis, and unsatisfactory treatment. Now let us see about the etiology of Acanthamoeba keratitis. The causative agent of this disease is Acanthamoeba castellani. This organism is found in soil, freshwater, seawater, sewage, and air. Acanthamoeba keratitis can occur both in immunocompetent and immunosuppressed patients. The mode of infection is direct corneal contact with any material or water contaminated with the organism. What are the risk factors for developing Acanthamoeba keratitis? Contact lens wearers have a higher risk for developing Acanthamoeba keratitis. This is because of the contaminated lens solution. Trauma can lead to Acanthamoeba keratitis, and Acanthamoeba keratitis can occur as an opportunistic infection in patients already suffering from viral keratitis or bacterial keratitis. This picture shows the trophozoite stage of Acanthamoeba, and this is the cyst form of Acanthamoeba. Acanthamoeba exists in these two forms, that is trophozoite form and cyst form. Now let us see about the symptoms of Acanthamoeba keratitis. There will be foreign body sensation, there will be pain. The pain will be severe and it will be out of proportion to the degree of inflammation. There can be watering, photophobia, blepharospasm, and blurred vision. Now let us see about the signs of Acanthamoeba keratitis. Infection is often unilateral. A ring infiltrate will usually be seen. The epithelium is intact initially but has a mottled dendritiform appearance, and later the epithelium breaks down. Radial keratoneuritis is an early pathognomic feature of Acanthamoeba keratitis. It is an inflammatory response of corneal nerves associated with perineural infiltrative process. It appears as thickened corneal nerves with ragged borders located in the anterior or mid-stroma and distributed in a linear radial pattern. Patients can also present with ring abscess. This picture shows radial keratoneuritis. It is thickened corneal nerves with ragged borders located in the anterior or mid-stroma and distributed in a linear radial pattern, as you can see in this picture. This shows a ring infiltrate which is seen in Acanthamoeba keratitis patients. This picture shows the formation of ring abscess seen in Acanthamoeba keratitis patients. Now what are the differential diagnoses of Acanthamoeba keratitis? Acanthamoeba keratitis can be confused with viral keratitis, fungal keratitis, or suppurative keratitis. How do you diagnose a case of Acanthamoeba keratitis? Confocal microscopy can be done and it reveals cysts of Acanthamoeba. Corneal scraping can be done and it should be subjected to KOH mount, calcofluor white stain, LPCB stain, culture on non-nutrient agar with E. coli, and PCR. KOH mount and LPCB stain reveal cysts of amoeba. Corneal biopsy can also be done. This picture shows an Acanthamoeba keratitis patient with fluorescent staining. Now, how do you treat a case of Acanthamoeba keratitis? Non-specific treatment includes cycloplegic drugs like 1% atropine. Systemic analgesics and anti-inflammatory drugs can be given. For example, drugs like paracetamol. Vitamin supplementation like vitamin A, B complex and C can be given for early healing of ulcer. Hot fermentation can be done and dark goggles can be prescribed to the patient. Now let us see the specific treatment of Acanthamoeba keratitis. Topical antiamoebic agents like diamidins can be given. The diamidins include propamidine, isothianate and hexamidine. Biguanides can also be given. Some of the biguanides are polyhexamethylene biguanide and chlorhexidine. Oral ketoconazole or itraconazole can also be given. Multiple drug therapy is usually given for many months. The drugs commonly used are hexamidine plus polyhexamethylene biguanide and chlorhexidine plus neomycin. Penetrating keratoplasty can be done in non-responsive cases. Thank you.
Pros and cons. In contrast to infection with other amoeba, Acanthamoeba can form cysts within the tissue. As a single cyst surviving in the cornea can lead to reinfection. The progress of therapy should be checked regularly, and ongoing infection should be monitored every 1 to 2 weeks. After clinical recovery, monthly checks are sufficient, ideally until 6 months after decline of symptoms.
So I went straight upstairs and cleaned my lenses, but I did put them back in again. And within 24 hours, my eye started to feel red and start to hurt. And then on the Monday, when I went to work, by lunchtime, my eye was angry and blood red. So I went to my local A&E, saw a locum. Funny enough, they actually took swabs and they did mention the word Acanthamoeba at the time. Sent my swabs off, but when they came back, it didn't show Acanthamoeba. So I was misdiagnosed a few times. So then eventually, after more tests, etc., they realised, and this was probably a couple of months, they realised it was Acanthamoeba. I couldn't work for probably 10 months. I had I had pain all down my left side, my eye, my face, everything. I had absolute severe light sensitivity to the point where I really couldn't go out for 6 to 8 months other than to come to my hospital appointments, but that caused me severe pain. My husband and I lived in darkness at home. We put blankets and duvet covers up on the windows to stop any chink of light coming through. I have more or less lost the sight in my left eye. I have a cataract in there now, which means I definitely can't see anything. Plus, some of the drops, unfortunately, made my pupil fully dilate and has stuck dilated as well. It's been very hard. I've had very dark times, but I've just tried to stay as positive as I can. I've got back on with my life. I work again, I ski, I drive, I do absolutely everything that I did before. The main irritation is obviously bumping into people when you're walking in shops, constantly having to keep looking to my side. I've adjusted to having one eye now, so it's not been great, but things could have been a whole lot worse.
Issue applied in Ecuador. In Ecuador, the incidence of this disease among contact lens wearers remains ever low, which indicates that this microorganism is relatively little virulent, that there is innate immunity in the host, and that the corneal epithelium offers a barrier against penetration of the amoeba into the stroma and consequent development of keratitis. Conclusion. The determining factor is the adherence of Acanthamoeba keratitis are contact lenses and their pure disinfection or hygiene, but with early diagnosis and conservative or surgical treatment. Acanthamoeba keratitis held in most cases.
Is a parasite which is actually ubiquitous. It's present in water, soil, so it's all around us. And it can affect the eye by leading to an eye infection in the cornea, which is the front part of the eye. Eye infections are not common overall, but patients who wear contact lenses are certainly at increased risk for getting any type of eye infection. And Acanthamoeba is not a common overall cause of eye infections, even associated with contact lenses. When it does occur, it's a very serious infection. It's very difficult to treat. So the best thing to do is try to prevent it. The most important way to prevent getting infections associated with Acanthamoeba are to really have good contact lens hygiene, since that's the #1 risk factor for getting this infection. If you are careful in terms of how you clean your contact lenses, store them, and wear them, and avoid situations like taking a shower with contact lens in your eyes, or going swimming in a lake with a contact lens in your eyes, then you can really avoid getting this type of infection.